Hello, everyone. Welcome again, another the live session of International Emergency Medicine Education Project, and we are discussing today emergency medicine perspectives of European students in our session. And before we start the session, as I do, I want to give some kind of information to you about the International Emergency Medicine Education Project. This is an international, global, the activity of the international emergency medicine enthusiasts and emergency medicine experts to improve undergraduate emergency medicine, and by providing the free resources for medical students and other trainees, particularly medical students and interns, and also promoting emergency medicine. And in this way, actually, there are two major supporters of this project. One of them is International Federation for Emergency Medicine, and the other one is the United Arab Emirates University College of Medicine and Health Sciences. Without the support of these two big institutions, it was impossible to actually establish all these platforms, all these educational resources for you. And of course, we have multiple platforms, mainly ien-student.org and ien-course.org. You can find multiple available free resources for your training, for your education about emergency medicine. And of course, Twitter, YouTube, Facebook, LinkedIn, and other social media accounts are available for the many of the other resources that we have. And today, actually, as an International Emergency Medicine Education Project, we do two types of live sessions. So one of them is we are inviting the emergency medicine experts around the world, and we are talking about the topics related to undergraduate emergency medicine. And also another event, which is today, Emergency Medicine Perspectives of Students Around the World, which is we are going to discuss today the European students. Maybe many of you know or you recognize already, but currently probably there are 82 countries around the world recognized emergency medicine. And you can, of course, imagine that some of the countries are mature, some of the countries are actually very immature, and some of them actually developing countries in terms of the emergency medical care systems. But whatever the systems in your country, there is always things to do about the training for postgraduate training or undergraduate training. So today we invited three speakers from Europe, one from the UK, which is Nadine, and other speaker from the Hungary, Elena, and she actually recently graduated, and of course it's very important to have graduated a speaker in these sessions, because she has probably fresh memory, and she may give a different perspective as a physician and as a new graduate, and of course her experience and Nadine's experience is very important to understand the difficulties and opportunities, of course, in the European emergency medicine. And we have another speaker from Slovenia. Maybe many of you already know Gregor Prozen from the social media or other international emergency medicine activities. He is the chair of Education Committee of the European Society of Emergency Medicine. And he will give us, general overview about the Europe. And of course, I'm not alone in this session. I have the very good friend from the Singapore, Dr. James Kwan, and he will be co-hosting this session together with me. And now I'm actually inviting Dr. Kwan to the stage. Hi, James. How are you?
Hi, Alpa. Thank you for inviting me again. Hello, everyone. My name is James Kwan. I am the current chair of the IFEM Core Curriculum and Education Committee. Really like to extend a warm welcome to everyone around the world joining us for another coffee chat event. I think we've had two of these now, Alpa, and they've both been very, very insightful and very useful for getting to know us, how emergency medicine, the experience of emergency medicine by our students across the world. Again, I'd like to thank you, Alpa, for inviting me to coffee and the opportunity to have this informal coffee chat with some of our student leaders from Europe and UK. Gregor from Slovenia, chair of the European Society of Emergency Medicine. Just like to say a little bit about emergency medicine. As a specialty, emergency medicine really provides many diverse and unique learning opportunities for medical students. And I'm really looking forward to hearing from our student leaders, their experiences as students in emergency medicine, and how, as an international community, we could better support them as students. So thank you very much once again for inviting me. I'm looking forward to having coffee with our friends from Europe. And back to you, Alpa.
Okay, thank you, James. Thank you very much, actually, accepting our invitation every time. It's very, great to have you. And of course, now you see the James and myself in front of the screen, but actually on behind the scene, we have another team member, which is Dr. Elif Dilek Çakal. She is controlling the all social media activities behind the scene, and in case we miss something, any comment, and actually she's actually helping us to and remind us to address that questions or comments if necessary. And I think, James, is there any ground rules that you want to mention, or?
I was going to mention some ground rules. As you're letting the students and our guests into the house, so for coffee.
Oh.
So as Alpa, you're letting some of our students into the house. I'd like to welcome those who have joined us on the different social media platforms. If I'm not wrong, we are on the IEM platform website, as well as Twitter, Facebook. And any one that I missed out, please let me know.
YouTube also, yeah.
And YouTube as well. And just a few words on housekeeping. This event is actually being streamed live on a range of social media platforms. You will not be able to speak during the event, unfortunately. Please share your questions, comments, or reflections on the social media platform you're using to view this event. We will be able to see your comments from all the social media platforms. And when I say we, Alpa has the control screen, and I think Elif also is in the background looking at these comments. Correct. As well, and they will let us know. We will attempt to answer as many questions as we can, although the time is limited, so we probably only get down to a few questions. And needless to say, please share your comments in a professional manner. Now, sit back, enjoy the event with your cup of coffee or tea or beverage of your choice.
Okay. Thank you, James. Yes, thank you. I think it's time to invite our first guest to introduce herself, Nadine. Hi, Nadine.
Hello. Hi, everyone. Thank you for having me today. My name's Nadine. I'm based in London. I'm a fourth-year medical student, and I go to Queen Mary, University of London. I'm really happy to be here today and share my experience with emergency medicine as an undergraduate sort of teaching in my university, and kind of see how that compares to everyone else and how it is in the UK and how it is in Europe in general. Thank
you, Nadine. Thank you very much, actually, accepting our invitation. I think I need to say this. You are also one of our authors in the International Emergency Medicine Education Project as a blog author. So thank you very much for your, for the submission is a great, actually, the post. So please keep continue.
Will do. Thank you.
And our next guest is Elena from Hungary. Hi, Elena.
Hi, everyone. Hi, thank you so much for having me. My name's Elena. I just graduated med school in June, so I started working in an emergency department here in Budapest. It's been really exciting, and it also gives very interesting insight into the strength and the weaknesses of medical student education in the emergency specialty. I grew up in America, but I was born here, and I hope to do residency in the US within this specialty. So thanks so much for having me.
Yeah, thank you very much. And also, I need to thank you also for your great, blog post submissions in the International Emergency Medicine Education Project. And thank you very much being one of our authors in the project. And our next guest, is Dr. Gregor Prozen from Slovenia. Hi, Gregor. How are you again?
Hello, hello, hello,
Hello.
Arif. Thank you for the invitation.
Of course. Would you like to introduce yourself?
Yes, I'm emergency physician specialist, specialist in Slovenia and holding European board exam. I am currently chief of our emergency department in Maribor, Slovenia, which is probably the largest general ED in the country, and I'm chair of educational committee of USAM. And I'm looking forward to this talk, especially in light of there will be a Congress, European USAM, European Emergency Medicine Congress next week in Lisbon, and we will be discussing about a lot of activities in USAM, education, and so forth.
Thank you. Thank you very much, Gregor, accepting our invitation again. I think we are all set and everybody here, and I hear you very nicely, seeing you very nicely. Hopefully, it will be a fruitful discussion. Welcome again. Yes, back to you, James.
Back to me. I guess I'm starting off again. Really, we really want to know a little bit more about your experiences. Actually, Nadine and Helena, you work in very different contexts, and Gregor, who's got this I guess overall view of how undergraduate emergency medicine is around Europe. How it has been implemented in various schools and in various forms and contexts. So it'd be an interesting conversation I think we'll have here. I guess let's start off with Helena. Helena, tell us about your experience in emergency medicine as a student, and now going into the arena, the working arena, how that has shaped your views.
Okay, so it's interesting because in Hungary, emergency medicine isn't a core rotation. So in our final year, which is our 6th year, we have to do multiple weeks of each of the 6 core rotations: internal, obstetrics, surgery. And EM is not one of these. So our only exposure to emergency medicine is really in our 4th or 5th year, 4th or 5th year, and it's only for 2 weeks, which for a specialty that's so phenomenal, it seems very, very little. It's also interesting that I have had experience in the US, so I have a little bit of an ability to compare the two. And emergency medicine in the US and in Hungary is very different in one major way, because in Hungary, emergency is split into traumatology and emergency of like the internal organs. I'm actually very curious to see if that's done anywhere else. I think it's similar in Austria, and I feel like it might have been the same in the UK, and that's why it's called accident and emergency. Accident being the traumatology part, and emergency being, the internal things. So I'd be curious to see if it's like that anywhere else in the world.
I guess that's I actually, to be honest, have no experience of how emergency medicine is practiced in Hungary. So that's given me some sort of an idea about how the specialty is organized. Perhaps, Nadine, you like to shed some light on your experiences so far in medical school around emergency medicine. I think, Nadine, you may be on mute.
Am I not on mute anymore?
Aye.
Okay, sorry about that. Yeah, so I think our experiences are quite similar to Helena, where we don't have much exposure to emergency medicine and the ED, so the emergency department, until our 5th year. So we also have one block which is 4 weeks long in our 5th year of med school. And our total number of years is 5 years, so it's not a 6-year course. And in this 4-week block, we have 3 weeks in the emergencies, so accident and emergency, and then we have 1 week in ITU. But I think the the main difference with us is that the medical school tries to incorporate emergency medicine throughout our learning, throughout the early years. But I guess it's sort of understandable that in your very first few years, you're so new in medicine in general that throwing a freshie into such a high-paced environment can be a bit scary. So what they try to do is when we're on our rotations, such as in respiratory or cardio, they try and give you some exposure to, let's say, emergency cardio, or we learn about respiratory emergencies. But besides that, a lot of our experience is very, very much what we do outside of medical school. So it's a lot of self-initiative and extracurriculars, which can go both ways depending on where you are in the UK. But that's sort of, I actually wanted to learn a bit more about that. Helena, do you guys have like societies? Like we have an emergency medicine society. Does that happen elsewhere in Europe? I'm not sure.
I know it's very common in the US, and that's where I got the inspiration. Actually, last month, I met with a really eager, enthusiastic fourth year student who said she was interested in emergency medicine. And I had the idea of starting one of these emergency medicine interest groups here in Hungary as well, because I think, like you said, a lot of it is up to you and what you want to do in your free time. But it's just so much easier if there's a group of enthusiastic, inquisitive students that you can share this passion with. So to my knowledge, right now that there is no such group, I don't even know if there is such a group for any specialty really. But I'm hoping that by starting this one, maybe we'll inspire other specialties and hopefully we'll get like young, eager medical students to join us.
Yeah, actually, it's quite important to have a kind of like-minded group of students in the college to do something, to organize something, and to train in some area together. It can be great. I think I don't actually. One of the difficulties for us as an international emergency medicine education project to organize this live activity. We started with the Africa, for example. African Federation has its own student council. So actually we contacted with them and we started with them. And then our second activity was with International Student Association, actually, and which has multiple international members as a student, of course, in that organization. And this is the third one. Honestly, we couldn't find the general European student council or student organization to communicate with. Probably, I agree with you, Helena. I think there is none as a general. And except the UK, honestly, which is I'm not working in the Europe, but I didn't hear or read any paper related to the student organization in emergency medicine in Europe. I don't know, Gregor, do you have any opinion about it, or any idea about it? Any student organization in Europe related to emergency medicine? You're muted, I guess.
Yeah, hi. I'm so happy to hear this enthusiasm and eagerness from our student colleagues, because this is exactly what European EM needs, right? Looking at the perspective of a European society, which the chamber that deals with education, that means we are primarily dealing with residents, right? Yeah. And residents, of course, are graduated students. So there can be no better match made in heaven if students already know what they have an eye on, and when they already know the passion that they have found, so they will much more quickly and seamlessly and with less stress jump into their residency. Now, the reality inside Europe, as far as I have heard about, is very heterogeneous, both in terms of residency programs and even more in terms of student interest group or rotation wise. So in my small medical school in Maribor, we actually are starting, how you call that, core rotation, so obligatory rotation in EM in fifth year. Before it was faculty, or how you call that, to just to choose, but now it's obligatory for all, which of course is great because we hope that we will inspire even more students to join EM. I think it is whole semester with some practicals and 12 seminars or something like that. I believe 5 points in this modern terms, this Bologna points something. Anyhow, considerable chunk, much better than what we used to have, which was nothing, of course. And as Helena said, it used to be that also in Slovenia, even up until now, a little bit, that traumatology, which is Central European concept, Germany, Austria, Switzerland, traumatology would deal with injured persons, and mostly internal medicine would deal with internal organs, right? There would be infectious diseases, plus minus, and there would be neurology at dealing with their disease spectrum, right? Now, there are, I believe, dozen plus countries with core speciality of emergency medicine, meaning they have full 5 years of specialty as standalone core specialty. And there are a few more that have even sup or supra specialty. Mostly supra, which means that one would finish off first specialty at the beginning, and then in additional, on average, two years, they would then be specialist of the stroke 1 and EM. And I believe since the Germany joined this club of supra specialities, and many specialities in Europe started as supra, not de novo standalone, I believe there are now very few countries left that don't have any specialty of emergency medicine, any form, and I believe there are Spain and Portugal. But the rest have some form of either standalone or supra or sub specialty. And I mean, for 28 or 28 EU members and bit of the neighbors. So this is roughly the landscape of residencies, which is of course mirroring landscape of standalone specializations as such. But regarding student interest groups, I think it's even more heterogeneous. And it's great, Helena, that you're thinking about making it up in Hungary, because I believe the next thing is that we certainly do have such club in Maribor, so I think you have to connect with our students. And there is certainly ultrasound interest groups, which are springing mostly out of the emergency focus groups, right? And I have heard of them in different universities. So there is definitely interest, but if you don't have a department at the university, it's all a little bit, I won't say illegal, but it's all a little bit underground, right? Which, to be honest, it doesn't really matter, because as long as you have interest and as long as it helps you, when it helps student to better focus on why they are learning all these things, I think it's great. And such IEM projects as this one can really network students, but most importantly, help, right? Help focus them. Because honestly, I didn't go to medical school to become a university doctor. But when I was in America for student rotation, it so happened I went to ED and I started to like it, right? And I thought I would never could deal with stresses and bloods and so forth. So I guess if I went there in nephrology, I would be a nephrologist there, maybe. But that's not the point. The point is that they lit the light, right? The light of passion, of interest. And then when I went back, I started looking, there was nothing. And that was in the time before internets, right? So then we had to develop on our own. But since 2007, 8, when EM went online, and when so many podcasts and blogs, and our host colleagues will remember, when so many blogs and podcasts came out, especially in EM, the community exploded. And I think it is only prudent and logical that you guys join the bandwagon, and I am being such a perfect, wagon already being made. There are already seats there, so that you join, and then you develop your own little bubbles of interest in Hungary and in London, and we developed here in Maribor, and then you guys, students, also connect. The only thing now I would finish with is I would strongly suggest or really strongly urge every student to join these groups in order not to waste time, but to gain precious knowledge, pearls, and to use these interest groups really to grow even faster. Because time, I see it's so short, 3, 4, 5, 6 years pass like this. And if you already know where you want to go, it will be such an invaluable asset later in residency. Merely not to learn not to learn skills even, not to learn the knowledge base, but at least to clear out the confusion, doubts, and so forth, which I see many residents have to deal with them for 2, 3, 4, 5 years. Some of them, I think, they're never really, ready. They're never really sort of decided are they ready or not. And if a student clears that away, and if you're sure that for next 40 years you want to do the best job in the world, then you're on a highway. Then you know what to read, what to listen, to whom to connect, where to log in. Then your growth will be skyrocketed. And that's great. I see our residents that were fully plugged in the also foreign educational materials. They are developing so fast, 3 times faster than I did before internet.
No,
I
no,
mean, it's very interesting actually that you talk
yeah.
about this, emergency medicine being very inspiring to our students, when they're in medical school, and some do become emergency physicians. But I really want to find out from both Nadine and Helena, maybe Nadine first. I guess emergency medicine. Not Gregor points out, pointed out that not everyone may become an emergency physician, but what I guess what we're interested in, or what I'm particularly interested in hearing, is what you learn in emergency medicine that you feel that may help you later on in your career. Because I guess that's one of the important things, is that what you take away from emergency medicine during your undergraduate years. Maybe Nadine, you can start off, and can you hear from Helena?
Yeah, gladly. So I think there's both a clinical aspect to it and a personal development sort of aspect to all of it. With my minimal experience, but I've been a few times in the ED just shadowing doctors, what I can really see that you learn from emergency medicine in an undergraduate setting is just the way the team works so well together. And in London, especially in London, the ED is so big, and the doctors all love to teach you if they're not too busy dealing with a crisis, of course. They love to teach you. They love to, nurture your enthusiasm for emergency medicine. And you start to realize that there's so much qualities that you need when you're a doctor that you can really learn in the ED, such as quick diagnoses, talking to patients. There's the aspect of, yes, you do want to know the patient's story, you want to know everything, but sometimes you don't have the time for that. And that is a skill that you just cannot learn out of a textbook. That is something that you just need to do again and again, and you just get used to it. So there's that. It's just quick history taking, what the problem is, and then the immediate switch to what do I do then? Because in clinics, you have, I don't want to say all the time in the world, but you have time, look at guidelines, think about what the next most appropriate step is. In the ED, you kind of need to know this very quickly. And, just making your brain work so quick is something that you, like I said again, you cannot learn out of a textbook. And I guess the last thing really is the UK focuses a lot on these things called red flags. And these red flags are symptoms where if you see them, you're immediately thinking, okay, this is not very good, or this person is very, very sick. And that is another thing that they do try and teach us in med school, but from my experience in the ED and from the doctors that have worked there, I just learned so much more in a 2-hour, 3-hour placement than I do in a whole year about something in the ED. So that's kind of what I think you learn as undergraduate student helplessly in the ED trying to keep up with everything. But yeah.
I think you're not alone. The red flags, and I think that's quite universal, if I'm not wrong, across the world. The things to look out for, the danger signs, I guess. Thank you. That was really, that's really insightful. You talk about you've had very minimal experience around this, but actually some people don't realize how much they have gotten from something until that later on, which actually is a great segue to Helena, because she's gone through this emergency medicine. Really like to hear from you, Helena, about your experience in emergency medicine as an undergraduate and what came out. What came out now that you are a graduate. You're a doctor. What did emergency medicine, what did you learn from emergency medicine in university that helped you, now as a junior doctor?
Well, first of all, I'm pretty reassured by what Nadine said, because it seems like the things she learned is very similar to what we learned. So like you said, just recognizing that a patient is sick is one of the key things, and it's very, very hard to teach in such a short amount of time, but it's one of the things that they focused on for us as well. The red flags, obviously really important. So that's reassuring to know that our education, very far away, hundreds of miles away, and yet there's so much similarity between them. That being said, I'm of the mindset that emergency medicine is something that every doctor should know, whether you become a clinical geneticist or an internist or a pulmonologist. Everyone should know these basic things. And I don't know if the amount of time that we have in the ED here is enough to instill some of these skills into people who don't go on to become emergency medicine doctors. So I think that's one of the things that we didn't learn enough is just what to do in a case of an emergency. When you do something long enough or often enough, it becomes routine. And since we're only in the ED just a couple weeks in 1 year, in our 5th year, it's not enough to get any of that routine. So I think that's one of the shortcomings of having this type of block system that we have here. But other than that, a lot of the things that you mentioned, like what I call the soft skills of just taking a patient's history, presenting to an attending, these are things that I don't think was focused enough on when I was a medical student. And now as a doctor, I find myself playing catch up and just trying to become more efficient managing my patients, more efficient writing notes. It's something that we didn't practice at all when I was a medical student. We normally just presented or we discussed a case together and presented it to an attending, but we never actually wrote our own notes. And now here I am, 6 weeks into a new job, and I find myself losing my mind trying to remember everything that I talked about and writing it down in a timely manner so that the patient's discharge is not delayed because I'm a slow typist. So these skills are things that have hit me as not even the clinical knowledge, but just the skills of being a doctor. They're very, very hard to teach, and you kind of have to grow into them as a new grad. So that's been a bit of a learning curve.
This is amazing. Actually, it's really how actually the different countries and the institution has the similarities and differences. But I definitely agree with you, Helena, and Nadine, and not, of course, our expectations. Not everybody, of course, will be an emergency physician, but every medical graduate definitely should understand how emergency medical care work in their context. They can be neurosurgeon, they can be cardiologist, they can be the other specialty in the future, but one day they will be asked to take care of some patients in the ED, and they definitely need to understand how this system works really. What are the, let's say, capacity to serve the patients? What are the limitations? So everybody has to understand. So that exposure, emergency medicine exposure, even if they are choosing the different specialties, I think is a must for every medical student, and it should be actually mandatory for every medical college. At least, now I'm going to ask this question to you, but according to the published literature, generally recommendation is that not minimum than 4 weeks, but if you are reaching the 6 weeks rotation and above, so it's getting actually more beneficial for the medical students to understand the whole concept of the emergency medicine or emergency medical care system. So what do you think about? I mean, I read one. I think one of the French the physicians wrote they have 7 weeks in the 4th year and 4-week rotation in the 6th year, almost 11 weeks, exposure for medical students in their emergency medical healthcare system. So what do you think? What is your opinion? How long it can be enough in your context?
So for me, I think it's great that they have, 7 weeks and then another 4-week rotation. We don't have that much at all. I haven't done it yet, so I cannot give a personal experience of it. But I completely agree. I think there's just so much benefit of having a longer rotation in the ED because, if you're a medical student and the university still wants to try and teach you all the different body systems, may as well just throw you in the ED. You will see everything weird and wonderful, and it just reinforces your learning, and it makes you have to think about your theory. It makes you have to up all of your skills. But yeah, sorry, I can't give you a very personal one. I haven't done it yet. It'll be next year, but yeah.
I think that French system sounds phenomenal. So I think we can split education into 2 parts. Is the theoretical, which is for the French system 7 weeks, and then 4 weeks of what I assume is rotation. So you're actually in the ED, you're doing shifts. And you learn by doing, especially something like emergency medicine. You could read about something 10 times and still not know how to manage that patient, because when you're there and you're the one making the decisions, obviously always supervised, but you're the one who's trying to make these decisions. It's so different than reading a clinical case in a textbook. So the idea of having theory where you get to learn everything that you might come across, you know, the basics. We have the 10 most common symptoms of EM, abdominal pain, chest pain, I don't know, dizziness. So knowing those and the core diagnoses and the things that you have to look out for, and then getting to put that into practice in your 4-week rotation, that sounds phenomenal. I think that in the future, maybe our country will move in that direction as well, of having a core rotation in your final year where you have to be in the emergency department, and I would be all for that.
Yeah, it is a real challenge, isn't it? I mean, if I think the most humbling experience that I have on a daily basis when I'm working in the emergency department is the elderly patient who's weak and dizzy. It's so it's a very humbling experience and very challenging as well. From potential diagnoses from aortic dissection to stroke to hypokalemia. It's really a really humbling experience to be able to get this exposure to undifferentiated patients. But I'm going to press on because I want to bring Greg on into this conversation by asking him, as a leader at USUM, in the education committee, if you could implement this system throughout Europe, how much time would you allocate to emergency medicine at universities?
Thank you, James, for question. Um, when I was listening now, 3-4 weeks, right? France 11. I don't know. I'm not exactly sure, but a month and a half seems like a nice, nice overview that you can get over. And as you said, it would benefit every doctor, not only those who want to go into EM. But the more and more is what you see, James. What you said, James. I perceive emergency medicine as the last bastion of general medicine as such, because all these specializations and subspecializations, the knowledge is exploding so rapidly that colleagues have to go deeper and deeper. But by that token, there is also guaranteed the growth of someone who will be a generalist, because who will take all this together and not to dissect the granny further down, but humbly put her together and solve her problems of as undifferentiated patient. So my answer here is won't be very exact, because I would say here I see two different roles of emergency medicine teaching. Is one that would teach us all these truly emergency and critical procedures and knowledge, but there is also the other, where we are sort of probably the guardians of good quality history taking, right? Because we are so much dependent on it. Guardians of good diagnostic method, of sound use of diagnostic tests, because we have to decide soundly every day. Even if we could pay that every patient would get an emergency MRI, we know that wouldn't benefit patients. So we are guardians of this core clinical acumen, right? That in other specialities is being lost because they already know what their patient has and they will do their fine things. So I'll put it differently. In Slovenia, we have since 30 years half a year internship in emergency medicine that every intern after medical school, so they're graduated, everyone has to go for 6 months, net of 5 months, into EM rotation. A bit of ophthalmo, ENT as well, but probably almost 4 months net in emergency department. And the idea was always that, as we concluded here, we have graduated as doctors first, and we are taught to present and care for our patients as doctors first and pulmo-oncologists second, right? We are to perceive the patients from a very holistic, all-around point of view. So doctors first, doctors with basal degree, doctors who can deal with immediate emergencies, and these doctors become residents in ophthalmology, oncology, trauma, and so forth. But always in their rotation, in their work, they should be able to at least address or come to the patient, start the procedure, start resuscitation, and then, of course, call for help and someone will take over, right? So, so I think if we look at the role of emergency from this perspective, then I would say this is like the medical school is like a bread of the sandwich, and emergency medicine is the first layer of peanut butter, right? And every student until end of their careers as doctors, they should have a taste, understanding, right, of this core core concepts. I was just teaching at the ALS course this week, and then you have to go back, what's new, and then you realize, you know what? After all, Peter Safar, 50 or 60 years ago, in one sketch, I think he said it all, right? What is there to say about ALS and CPR, right? I mean, it's nothing completely new. And this is what it is. There are some eternal rules to this art, right? And this is how you approach the patient. This is how you ask the patient. This is how you tease out worst first. And this is how you prudently, economically, sustainably go forth with first set of diagnostic tests and second, and you decide what's in patient's best interest, what they would want, and not what someone can jump on you or someone will legislate you, but to do it in a very humane, sustainable sustainable point of view. This is what we are trying also to teach our interns and students, and of course residents, to do what is right and not what is in the contemporary vogue or what we have heard at the congresses for, but what's to do what is right. And these things are more eternal, right? And they don't change with the guidelines as many times as the
Yeah,
guidelines.
Gregor, you're making me hungry with this peanut butter
Peanut
and
butter.
sandwich type analogy. But what you say is true. There are certain things that we probably have. Our students. Emergency medicine helps our students to learn. But this is where I want to tackle this is a good way to get to the next topic, because the issue I think here is that you can allocate half a year to emergency medicine, but the student may not learn anything.
Exactly.
And this is what I want to talk about actually with our students about the clinical learning environment. See, that's a really important thing. So there are challenges in that emergency department. I think Nadine came up, when she spoke, she said, look, our preceptors are happy to teach us, assuming that it's not too busy. So I caught on to that, and I'm just thinking, what's going on there? Maybe I'm going to switch the conversation from you, Gregor, to Helena, because she's, I guess, been through this both ends of things. Can you tell us what challenges that you faced as a student, learning in the emergency department?
So that's exactly one of the things that Nadine said is that, and now that I'm a doctor and I have students under me, I realize how much energy and extra time you need in order to work side by side with a student. So the
Mm,
second a student comes, your patient per hour it shoots down, but it's worth it. But there's also the give and take. So I finally understand how hard it is to treat your patients, but also give quality education to the eager medical student who's with you for the day. And yesterday I had a student with me, and after the shift, she thanked me for all of the explanations I gave and all of the things we got to do together. But in my head, I was grateful to have taught her, but I was also thinking, now I'm so behind on my documentation. So this is a challenge that I think everyone can feel, but my emergency department started a thing last year that I think is part of the solution. So now, when we get our monthly schedule, every single day that students as a group, like in their fourth year, come to the ward or to the ED, there's one doctor who is assigned that day to be with the students, and he is not on shift. He's not, or she's not actually working. She doesn't have any of his or her patients, but the only role that she comes into the ED for is to teach this group of students. And I think this is paramount in ensuring that students who are there get one doctor's full attention, because by not having any patients of your own, you're able to float around the ED and pop your head into interesting cases and discuss these with the students. So I think this is a pretty good idea that my ED started doing last year. I'm all for it. Um, what was the other part of your question? I've forgotten it.
That was it,
That was
Elena.
it?
Is
Okay.
that either you've seen the whole spectrum? I picked up on something Nadine actually said. So, I mean, Nadine, you clearly have had good learning experiences, and you clearly have had not so good learning experiences, and I guess, or more challenging learning experiences. So, I think that's where that my question was coming from. Nadine, do you have any other anything else to add to in terms of learning experience in the ED?
Yeah, so what Helena said was very interesting because we have something very similar where um, if the ED shift is through our university curriculum, then we have doctors that are in charge of organizing this for us, and it's very well planned. But what else we have? We have an emergency medicine society at my university, and through that, one of our activities is called a studentship scheme, and that's where we get this is the bulk of the undergraduate exposure to the ED because we know that first, second, and third years, even fourth years, you guys don't really get any exposure. So we organize and we contact doctors who are willing to have students, and then it's all a gigantic Excel spreadsheet, which is horrible, and then we put it out to the students and we sign them up with doctors and they get to go on these shifts. And the benefit of something like this, and I probably shouldn't be saying this, but when it's through the university, sometimes the they choose like a consultant who's in charge and of organizing the medical students to their shifts, but then they kind of just dump you onto the foundation doctors, so our trainee doctors, because all those trainee doctors, they have to do everything the consultant says. So they kind of just dump us on them. It's like, oh, are you the SHO on call? Are you the foundation doctor on call? Okay, you're taking this student, and they don't really know, like Helena said, like they have so much work to do. They barely have time for you as well. But when you do it through the students and you contact the consultants ourselves, they are giving you their rota, they're prepared for you, they want to know what time you're coming, and the education is just so much better. And the last thing is just like, I think someone said in the comments about student engagement is the most important thing, and it really is, because if you're a medical student that doesn't want to be in the ED and you're there, you're going to come out of that 5 hours later not knowing anything more than when you went in. Like the students that really want to learn, they're already looking at, oh, what can I learn in the ED? What can I do to help my own education? And that's what you really need um, from the community.
I guess you're so spot on. This isn't. You're not the only one that has said this. Locally, our students also say this as well. It's really achieving a balance, really. To see the kind of work that what you're going to be in for, I guess, when you come out as a doctor, but also to ensure that you have a positive, good learning environment as well, to achieve that balance between both, being supervised by a consultant and being supervised by a junior doctor. It's actually achieving a balance. And yes, you're not the only one that has brought that up. And I think that is a challenge. So I'm going to bring this back to Alpa. Alpa's chair of his department, professor of emergency medicine, and he's the lead for his emergency department. Alpa, what are your thoughts on that?
Actually, there is a misunderstanding, I guess, here. James says I am the department chair, but in my college, emergency
Yeah.
medicine is not a separate emergency department yet. It's under the internal medicine, because we have a two faculty here, and then under the internal medicine, yes, I'm actually chairing the internal medicine department. So it's a
Yeah.
kind of quite
Okay.
interesting.
All right.
Uh, it's quite interesting experience. But definitely, I'm working with the Tawam Emergency Medicine Residency Program, and our emergency medicine training in this college started 8 years ago, 9 years ago. And with start, I think the 4 weeks program we started directly and adopted the Society for Academic Emergency Medicine Education recommendations and International Federation for Emergency Medicine recommendations. And since then, we are actually improving it. And we are, of course, working with shoulder to shoulder with the Tamam Emergency Medicine Residency Program faculty members and senior residents, as well as that we are doing of course, didactic teachings, practical skills teachings, and of course the assessments. And we are organizing all together to these activities in the college. But I definitely agree with the emergency environment is very busy environment anyway. I mean, every time you go, there is something make you busy. And this is very true for the consultant physicians, definitely, and even the residents also. But unfortunately, we have to transfer our knowledge to next generations. And one of the best thing to do it is actually working with your students, side by side, in every critical situation, in every patient. And actually, even just saying one word about that patient may change everything for their life, to take care of similar type of patients. So what I want to stress is, of course, there are some recommendations for the emergency medicine clerkships or rotations for medical students. There are curriculums for this, actually recommended curriculums, 4 week, 6 week curriculums, and topics are already defined clearly. But the most thing I guess the students can get benefit from the emergency medicine is a kind of this hidden curriculum, actually a lot in everywhere, but a lot also in the emergency medicine. There are so many fine tuning areas needs to be shared with the medical students, which they cannot get this information from any rotation and any textbook, unfortunately. Sometimes this information system based, sometimes is patient based, sometimes actually it's just a communication issue. So there are multiple hidden curriculum areas that we need to address during this side by side working, the shifts. I definitely agree that the having, and I really amazed actually. Helena said that they have a kind of teaching shift one person responsible for the medical student teaching. This is amazing luxury, actually. It's an amazing thing. So how I wish to every department, every hospital have this mindset, because students are our future at the end, and we will be sick one day, and they will take care of us. So why not we share what we know at this moment when we are actually still active in teaching and working, of course. I don't know. What was it, the question that you were asking me, or I just
Yeah, yeah. I mean,
conversation somewhere
how,
else?
how can we make this? We've heard that, both Nadine and Helena have outlined different learning experiences. Both positive learning experiences and more challenging situations where they felt that perhaps they could have learned more
Yeah.
at the time, or learn something differently, or learn something that has achieved some sort of a balance. So, from a balance point of view as well, is to have an insight into, the different, I guess, different teachers bring different things to the table, and it's a co-learning experience. I think this is a although we say it's an immersive learning experience, it's actually a learning experience with both, the supervisor, preceptor, and the student together. They're learning something together, and I think
And,
that's
and
that's
actually,
really important.
James, I just want to add something. Of course, we do, the feedback, for surveys
Yeah.
coming from the students. Actually, I don't
Yeah.
know, is the experience the same with the Nadine or Helena, or maybe Gregor can say something. But our students, for example, repeatedly mentioning that they're actually learning a lot from the residents rather than the
Mm.
attending physicians. So they're explained also, and attending physicians are always busy. They're seeing the patient, writing the charts, something like that. Of course, the residents are busy too, but somehow, in our setting at least, the residents are more willing to teach the students than the attending physicians. I don't know, your experiences are same or not.
I think that part of that is because residents still remember what it was like to be a student and what it's like when you're just standing
I
at
was
the end of
gonna
the
say that.
room and nobody talks to you and you
You
feel
killed it,
awkward and
Helena.
you just want to go home. Um, but that's one of the things that frustrates me is that your experience in the emergency department is so dependent on who is on shift that day and who you get assigned to. Sometimes it's a very, very good attending, sometimes it's a phenomenal resident, but it could also be the opposite. And I wish there was a way to standardize this experience or to ensure that at least everyone gets a little bit of quality learning so that it's not so dependent on just random luck. Because, as Nadine said, we've also had doctors that will either send you off or like pass you off to another person who doesn't know you're coming, doesn't have the time to teach you, or they'll just send you home early. You're there for an hour and a half, and then they're like, you know what, go home. I have a lot to do. So I wish there was a way that we could standardize this so that all of our students would have not necessarily a good experience in the sense that they fall in love with emergency medicine, but a quality education.
Yeah, so
Yeah.
true.
I was just going to say the exact same thing. I think the residences, or as we call them, the foundation doctors, they just see the fear in your eyes and they just think, you know what, let me help you, let me teach you something. But there is something recently. So for this might get a bit technical, complicated, but after we finish med school, we have these 2 years called foundation years, and these are basically residency or trainee years equivalent, where you have 2 years and it's general. You don't specialize yet when you're at that point. But what they've released recently is something called the SFP, which is called the Specialized Foundation Program. So you can either apply for the core normal foundation program or the specialized foundation program. And the benefit of doing the specialized one is that you have a block of time. I'm not sure about the specifics, but during these 2 years, you have a block of time where you do what you want to do. And that can include, some people love research. So you can then take a few months out of your clinical placement to do research in a lab somewhere, or a lot of people are interested in medical education. So when you have those blocks of time allocated to medical education, you can be a clinical doctor who is in charge of medical students. And I've met one of the foundation doctors who did something similar, and his whole entire time there was dedicated to teaching us. And obviously, we got the best education we could possibly wish for from him. And I really don't know the specifics. I think he did pick it specifically for that, um, the topic he was doing, which was gastro. But, if we can get doctors who love medical education doing it in emergency medicine, that's also, I guess, one of the ways to really get good education in that area.
Yeah, so true, so true. Gregor, would you like to add anything about your setting, or maybe in a general in the Europe, because you're talking with multiple leaders because of your position in the USM, and anything you want to add? I think you are muted.
Mute.
We have to sort of recognize that EM is still an infant development in Europe in on average, or rather, okay, now it's a little kid, not infant anymore, but definitely developing. And the bedside teaching, as such, outside Anglo-Saxonic environment is quite a rarity. Let's say with Helena, we are coming from Austro-Hungarian imperial pool, where well, it's quite striking differences between the nations. So in Central Europe, in the imperial old world, you don't ask too many questions of your seniors. You don't ask. You don't oppose. You don't question. You sit back. You absorb and wait until 5, then you flee. Whereas in English model, I don't know how, maybe from Americans, but this is where probably where James grew up, right? You adopted this Commonwealth model of British medical hierarchy, but also some form of sound, common sense mentorship, and much more specified learning goals, learning outcomes, specified methodology how to get there, and specified role of mentor. And this is so different throughout Europe. And this is something that we in continental Europe have to look forward. Although, to be honest, Generation Z or whoever Epsilon that is Y that is ruling now, I see this generation has no problem asking anymore. This is something you guys, students today, are really a completely new phenomena that defies geography, and I can immediately tell you are of a new breed. You want answers, you want them now, you are constructively impatient, waiting for answers, and you certainly don't have too much fear, if not fear, certainly not no fear, but okay, a bit of respect for hierarchy. And this is something that we as teachers will also have to adapt. I used to be a student 20 years ago, resident a decade ago plus, and I always thought that they are not teaching me, they're not talking to me, as much as I saw it done in America, or as, let's say, Alper did when I visited his ED back in Turkey. And I thought, well, my teachers, my seniors, they don't know, they're just too ignorant to pay attention, or, I thought there's some inherent subjective reasons. But as you girls pointed out, teaching, clinical teaching, next to quality clinical care is hard. And I think this is the main reason and main impetus why it is not done more widely. Even micro teaching on the fly, even giving some student a short explanation what is happening, 2 words, 2 sentences of explanation, because it's hard. Because after 12 hours, you are drained as an attending. I'm drained like a sponge, and this is why it is all the more important and all the more plausible that some environments or units, departments recognize the need for reserved time for residents, reserved time with students, and reserved time for faculty to do only that, to do teaching only, even if for 6 hours. Um, USEM is trying to develop accreditation process for residency programs throughout Europe, and even now in these initial talks, it is so clear that Europe is so heterogeneous in terms of even accreditation. There are questions like, is it even sensible? Is it realistic to ask of the institutions? Because surely we know this accreditation part is missing. The system is just not mature enough yet. So hopefully, through many different platforms and many different activities and raising awareness, we will unify, systematize, and prioritize what is truly needed for quality clinical teaching, both for students and for residents. Uh, there will be some guidelines coming up soon. So hopefully those leadership will take up the baton and realize the need for reserve time, mostly for reserve time to teach students and to teach residents to help them come across. Because as we've heard before, investment in students and residents certainly pays off. Because once they are in the mid level or they are independent enough, they can work for you, and that's such a worthy price when you see young doctor develop into a young independent physician taking care of patients, taking quality and respectful care. That even with all the stresses, it gives me enormous pleasure and joy to see that, yeah, in the end it works. We are producing quality, heartful doctor. Thank you.
Thank you. All right, I think we are almost coming very close to the end, but there are some areas that we didn't touch yet. I mean, I want to ask first the Nadine and the Helena, and of course the James and Gregor, even to myself. How societies can work with medical students and improve the undergraduate emergency medicine as it should be. Of course, it is not an easy task. And is there any hope about this?
I can say.
Yeah, there's lots of hope, definitely. Um, I think personally, I'm not sure about, bigger national, almost societies, how they can really help. I guess if they work together with the university to make our ED placements, albeit short, if they make them the best possible, help them with organizing education, or even giving, resources or a framework that the hospitals and the doctors there can follow, um, to help better our education, that would be ideal. On top of that, what I do know, and this is a bit more to like the funding side, unfortunately, is the university societies, if we hold conferences and stuff like that, we like to host like pan London conferences. So with the other schools, and those things are very hard to run. It would be lovely to get any funding, not for us, obviously, for the venue, for catering, giving us contacts that, like, for speakers that could talk at these conferences. That's always, it's very hard for us to get a speaker who's so good at what they do, because they have to come and talk to medical students. And I think the last thing is really, we didn't touch on this in the chat, but FOMED, so education, free access education. I know there's a lot in the UK. One of the ones, for example, that I like to use, because I'm quite also interested in pediatrics and pediatric emergency medicine, is Don't Forget the Bubbles. And their Instagram pages are always filled with fun resources, fun free courses, fun free videos, all of it. It's really exciting to look at, and it helps reinforce our knowledge. And, even IEM could have, our Instagram page where they post foam education, or things like that. So that's what I think you guys could probably do to help and nurture us as EM enthusiasts.
I love your ideas. I think you bring up a very good point with funding. We're just starting the group, the EMIG, in my country, so I have no idea what it's going to look like. But I've already talked with the girl that I'm working with, and we've thought of doing workshops. So, for instance, if we were gonna do a workshop where we practice doing peripheral IV lines, their first, second, third year med students, they haven't done it on a patient yet, they just need to learn the maneuvers. We need some supplies for that. And it's not a lot of money, but it would be great to not have to ask the students to pay for the supplies if we had a little bit of funding. But that's just a small example. Conferences, obviously, anything that we organize for the students, just to have a bit of money, great. And then the other things that you mentioned, all good ideas, all for them as well. But one thing that would be great would be exchange programs. So the ability of a student in Hungary to go to Slovenia to spend a month in the emergency department there. So of course, language here is a big barrier for countries like Hungary and Slovenia, but a lot of people speak English. So if there was a chance for somebody to go to the UK for a few weeks of a rotation, I think the things that you learn from another emergency department, they somehow stick with you better. And it also gives you the ability to see the strengths and the weaknesses of your own ED, and by therefore make improvements in your own country. So if there was a way to organize medical students rotating at other countries, even in the EU or in the US or in Asia or Africa, we could go anywhere. That would be phenomenal.
Right. Anything you want to add, James?
I think hearing from all this, I'm going to take the it's not the opposite perspective, but from the other end of how we can improve that clinical learning environment for our students. I think the first thing really to say is that we have to really value that our medical students who rotate with us through emergency medicine are going to be our future. They're going to be working alongside us. So I think what's really important is to build that capacity to recognize that this is our future. We cannot keep thinking medical students, we're too busy to look after them. There's too many things going on. We keep making that excuse. I'm sorry, I have to say this again and again. We're too busy. We're too busy. We're too busy. There is a time and a place for all activities within the emergency department. It doesn't mean that our students are not learning when they're engaged in a different activity that does not, let's say, require that immediate attention of the senior specialist itself, or the specialist or the consultant. I think what's really important is to recognize that our students actually, there is value in dedicating time to our students to help them learn, and how that time is allocated in terms of valuable learning activities. I mean, we can list a variety of learning activities, and our teachers are not just limited in the emergency department to our emergency physician specialists, but also we must remember our nurses. We learn from our nurses, we learn from our physiotherapists, we learn from occupational therapists, we learn from our junior doctors, we learn from our middle grade doctors. So, and we learn about how we work together as a team with other specialties. So I think one of the I take home points for me is that how the challenge of making that emergency department learning environment to be a positive one, to integrate as many of our teachers as possible, and not simply look at an individual teacher as the only teacher during a shift, but as a teacher that there are many teachers within the emergency department, there are many supervisors, and how we work together as a team to make that positive learning experience. I think that's the key. I think the key is to try and move forward towards that approach to learning within the emergency department. I think that's really, really important. And I think it does take recognition from both our side, from the supervisors or the teacher side, but also from a student perspective as well, to recognize that perhaps there are other teachers within the learning environment that they can gain from during times when their consultant supervisor may not be available. So I think that's the biggest challenge that I see at the moment in creating that positive learning environment, is to ensure that both our learners and our teachers can work together. I think that's probably the key to creating that positive learning environment for a specialty that can provide so much in terms of learning to look after our patients, especially our undifferentiated, critically ill
Yeah.
patients. So that's my sort of take on on what I've heard today.
Yeah.
Thanks.
Uh, I just want to change the topic a little bit because we almost come to the end. How do you think this IAM, International Emergency Medicine Education Project, uh, should work on this? I mean, is there any areas that you guys can recommend the project can look for and work on, or organizing something or doing something, or or new resources that we need to have for medical students? Do you have any recommendation for us for future activities that we can take care of?
Yeah, I think it's quite similar to what we've already said. So the whole idea of education and being able to access it everywhere, I think would be fantastic if IEM could work on. And that can be in the form of, resources, MCQs. MCQs, everyone loves MCQs because they help us with our studying and our university exams. And, videos and along that line. Um, Besides that, I think it would, what I've seen that medical students really like is educational talks. So we're very fortunate here. We have a lot of educational talks in the UK. There's tons of, foundation doctors who organize their own talks. on specific subjects, and you can go, they're free, or it's just if you want to do it in your own time. And I think it's a lot to ask for, but if IEM would like to do that and they can do talk series, we had a talk series last year called the EM talk series, so emergency medicine talk series, and we're very lucky every month to have one talk on, let's say, rest EM or one talk on cardio EM. And I think that would be great if if you guys could organize something like that. And it would also give us a lot more perspective because it is international at the end of the day. It will be different from what it's like in the UK.
Yeah, thank you. Great suggestion. Actually, we will look for it definitely.
My suggestion goes a little bit along with what Nadine already mentioned. So she said that it would be nice to have a curriculum, I think she said, and I agree. In the US, I think SAEM has a clerkship core curriculum that they have students go through. And it would be nice if the international group would have an idea of what kind of things emergency departments should try to teach their students. I think since it's such a new field and it doesn't exist in many countries even now, as new countries are creating emergency departments and are finding that they need to teach this specialty that they've never ever educated before, it might be nice to have a resource for them, for the faculty members, something that collects all of the key diagnoses that you guys think is something that every EM clerkship or EM rotation should cover.
Yeah, great suggestion. Thank you so
Yeah.
much.
Alpa, I'm going to bring that back to you because Helena actually said something about an international curriculum
Yes, it
for
is.
medical students. Tell us
Yes.
more about that, Alpha.
Yeah, of course. Actually, a couple years back, in the IFEM, in the Curriculum and Education Committee, and we decided to update the current recommendation of IFEM, which is published in 2010, about the undergraduate emergency medicine training in medical schools. And we reviewed, of course, the recommendations, and we, of course, searched, for all publications related to curriculum, undergraduate curriculum. And currently, actually, we are in the final stage of this curriculum to be, to go out after the, of course, approval of some certain steps in the IFEM. So I can definitely positively can say that in the next ISEM conference, we will be presenting, hopefully proudly presenting, recommendations decided by multiple international emergency medicine educators' votes, and what is important, what is necessary, what is good to have, or what is not really necessary during the whole training of a medical student, during the whole years of medical training. And of course, there are some topics come up very clearly on the surface and kind of creamy area, which is every medical student, definitely should learn during the medical student period. But of course, the when to teach them, how to teach them, is definitely depending on the context of that medical students actually, getting education. So therefore, we will give, of course, the freedom to decision makers in the institutions, in the countries, to use them for their medical students' benefit. But it is very surprising to see that the things are very similar around the world, and decisions are really similar around the world as a emergency medicine, the educators, and they're almost all of them actually choosing the same topics or same areas that every medical student should know this stuff before they graduate from the medical school. So I can say that I think in a couple months it will be ready for the first draft. We're hoping that before the new year, if not in January, hopefully. And then it will go to some kind of certain, quality assurance processes, let's say. And then it will be ready totally for the world in the ISAM, the conference in Australia. And I know SAEM. We have friends in SAEM, of course, and they are working to update their curriculum also. But what is the difference between us and the SAEM curriculum? It's of course the U.S. is a very big country and very developed systems, and of course they are looking, basically the U.S. system to develop their the curriculum. But international federation actually looking for a little bit broader, and what is minimally required for every medical graduate around the world, including US, including Turkey, including UAE, including Singapore, Slovenia, or wherever it is. So Brazil or whatever. So it's actually it's a kind of more broad coverage about the recommendations, but definitely it can be detailed one by one by using properly in every setting, because very general and direct the recommendations. I don't know, James, did I miss anything or
No, 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 no. I think it's more of an understanding that there are the must-haves in any undergraduate medical curriculum that it's been decided from a consensus type process. We've got uh, representation from across the world, where we've put this curriculum to them, and they have, in a way, voted to keep certain things in and to make certain things essential or a must-have. But I guess that's something that Helena brought up, which was that core curriculum, which is essential. But the other thing I actually wanted to say was I'm really quite excited about this, that at the next ISEM conference in Australia, ISEM 2022, we will be having a medical students summit. At that time, we will hopefully have some form of getting some sort of consensus and views from a wide variety of students. So it's an event designed for students with us in the background and listening to your thoughts and suggestions, and hearing your experiences and also sharing what you feel is important in the emergency medicine community. So that's something to look forward to as well. So I wanted to bring that out. Hopefully, the ISOM organizing committee will allow us to run this event. It will be a virtual event, so to have as many students involved as possible. So we're hoping and we're trying to get everyone together and get everyone's views and listen to everyone and get that broader perspective.
yeah. I just want to ask final question to the Gregor, which is the European Society is going to have their national. I mean, I'm sorry, the yearly conference, annual conference next week, and the Gregor. Do you think under the European Society in the future there can be some kind of chance for the medical students, for group or council or committee that brings the all European students together, because apparently Europe is very big and there are varieties in the systems already between the countries, and students may not have chance to have group to communicate within their country. So do you think the European Society can do a kind of connection type of initiative for the medical students, or it's in the agenda for later years?
Arif, this is such a great idea that I will double check if there's anything like that happening, although I haven't heard directly. And if not, it will definitely be put up to board, because, as I've read somewhere, yes, it's that simple. Students are future, residents are our future colleagues, and it's best to, how should I put it nicely? but it's best to mesmerize them, right? And make them fall in love. The earlier, the better, because then they'll come our way.
Yeah.
And I have no qualms to shamelessly recruit them as long as they want to be recruited. And yes, it only makes sense. It only makes sense. Thank you. And I hope next time be able to report on something positive, because as you said, either IM or IFM, all these transnational societies, their main role and the truly indispensable role is networking. The rest you can find somewhere, somehow, someone has already thought about it, podcasted about it, and so forth. But the platforms, the networks, this is why we are here. And the network is as strong as many active members it has. And we should help students to connect themselves. And that's only good for society and for speciality. Thank you, Arif.
Thank you. Okay, I think it's time to finish now. We are almost over 9 minutes, I believe, according to our defined time frame. But it was very nice talk. We learn a lot. Hopefully, the audience learn a lot, and we thank some of the viewers. They share their opinion and questions, and thank you so much. And hopefully, we will see each other again near future, and definitely we will keep in contact each other to improve the undergraduate emergency medicine for the benefits of our students. And yeah, that's all, I guess, and from my side at least. And I just want to give the word to James, Nadine, Helena, and Gregor, or maybe Nadine, Helena, and Gregor, and then James, and then we can finish this session, I think. Yes, Nadine.
Yeah, thank you so much for having me. It was so interesting to learn about how emergency medicine, the curriculum is across, Europe, not just in the UK. And I think this idea of a core curriculum is fantastic. I think all medical students would love this, whether they are interested in emergency medicine or not. And I really look forward to the conference that's possibly happening.
Thank you. You are muted, Helena.
That's how we know that it's getting late here. So it was an honor to talk to everyone and to get to meet this really motivated group of individuals. I'm really looking forward to what comes next. And now that I know that there is such a support for student groups, I know that I can reach out to you guys. And if there are students who are interested in communicating across different countries in Europe, you can also reach out and maybe we can get together a group. So see you guys next time, and thanks so much for having me.
Thanks, Elena. And final words from Gregor.
Yes, thank you for the invitation. And let's do something. Let's go back to our societies, our networks, and help students connect themselves, because the future of EM is bright, and with them, it's even brighter.
Thank you, Gregor. And we want you to know that the International Emergency Medicine Education Project and, of course, the IFEM are always willing to collaborate with organizations and institutions and committees. If you need anything from our side, we will be happy to collaborate and share our resources and our time.
Thank you.
Yes.
Thank
James.
you, Al, for inviting me again. Actually, it's I would like to say that it's always a very humbling experience to hear about emergency medicine from a student's perspective, how they see learning in emergency medicine, the kinds of wonderful learning experiences, as well as the challenges that they face. I think that's always humbling to hear that, and I'm very grateful that both our students are able to spend some time with us. I do. I do want to also thank Gregor as well for providing his insight into the broader perspective of Europe, as a region, and how different things are across different countries. So thank you so much, Nadine, Helena, and Gregor, for coming to the session. And Alpa, thank you for the invitation again.
Thank you. And I think we can wave our hands now to say goodbye to who is listening now. I don't know, but yes, bye bye, everybody. And I just want to say again, please to share our resources with your medical students, your colleagues who thinks they may get benefit, and also the who is watching now. I don't know, but they can definitely follow us through the Twitter to get up to date activities and products that we are actually delivering for the community. All right, thank you very much, and hope to see you soon again. Bye bye.